Welcome, everyone, to this panel session entitled Becoming an Executive Surgeon Leader, How to Step Outside Your Practice and Lead a Program. I'm Brian Zimmerman, the Custom Content Editor with Becker's Healthcare. During this session, this group of distinguished surgeons will share details from their own leadership journeys. This is a great group, and we've got a lot of ground to cover. But before we dive in, I'm going to ask each of them to introduce themselves and tell you a bit about their roles and their organizations. And Dr. Martino, I'd love it if you started us off with that.
Great. Thank you very much. And welcome to our panel. It's great to see everyone today. My name is Marty Martino. I'm a gynecologic oncologist, and I'm medical director of our robotic surgery program at the Lehigh Valley Health Network in Allentown, Pennsylvania.
Thank you, Dr. Martino. Dr. Stiflman, how about you go next?
Hi, I'm Mike Stiflman. I'm the chair and professor of urology at the Hackensack Meridian School of Medicine. I'm also the director of robotic surgery for the Hackensack Meridian Health System. We currently have eight of our 15 hospitals with robotics, and I help run that program as well as align everybody on to best practices and initiatives.
Thank you so much for being here, Dr. Stiflman. And Dr. Phillips, why don't you round us out here?
Absolutely. Welcome, everyone. I'm glad you could make it today. My name is Melissa Phillips. I'm a general surgeon at University of Tennessee down in Knoxville. I've been doing robotics since 2016 and taken a very active role in our leadership, being able to upgrade our systems to currently 5 of the 4th generation systems and working a lot with our administration on showing cost value benefits. So looking forward to bringing that perspective to everyone today.
Thank you, Dr. Phillips. And, we can dive right into the questions here. And Dr. Phillips, you can actually start us off. And Dr. Martino, Dr. Stiflman, you can weigh in as you feel fit. So the first one is, we hear the phrase surgeon champion a lot. So I'm wondering if you can distinguish for our attendees today, how is a surgeon leader different than a surgeon champion?
Absolutely. So to me, really the biggest difference between the surgeon leader and the surgeon champion is the level that they're working on. Most of our surgeon champions are focused either in a single surgeon practice or a service line. Their group in general surgery, their group in urology are able to promote robotics very, very well within that group. Both groups of these are effective at bringing about change, but what really makes that surgeon leader to me stand out above that surgeon champion is for the ability for that person to look at an institutional level, to look more at that programmatic function level. So as an example, the surgeon champion loves their outcomes from their MIS robotic report or results, They enjoy sharing that. They enjoy teaching residents. They're a great team member and they're wonderful at promoting robotics. But that surgeon leader takes it to the next level. They collect their data and they take that data back to their administration to share what benefits they're able to offer and to take that more to the hospital level. They work with their teams on block time allocation, even if it means that general surgery needs to give up some block time because GYN oncology is rocking the world of robotics right now. That may be what's best for the hospital, not just me as the surgeon. And to me, that's the big distinction, is that level of difference in their focus of where their enthusiasm is going.
Dr. Martino and Dr. Stiflman, I know you both got stuff to weigh in on there so let's go with Dr. Martino first, and Dr. Stiflman, you can.
Thank you. Melissa, it's true. Early on, as we started in 2008 with just gynecologic oncology and urology, and I've been fortunate to work with Dr. Stiflman as our programs have grown, and we've really brought in our general surgeons. So I think that, just as you said, that surgeon leader, as the transition occurs, is to encompass the team approach and really collaborate and build your team members across the network. So, Mike, what do you think?
Yeah, I agree with everything. And, I think a big distinction for an executive surgeon leader, an ESL, is they're sort of the interface between administration and the surgeons, and also the surgeons and the folks that are doing the day-to-day work, the nurses, the people doing the scheduling, their PAs, and they have to bridge that chasm. And they're the ones that need to articulate what the needs of the program are, why they're so important, how they marry up with the quadruple aim, which is what most executive hospitals look at. And they also need to execute the strategies and the initiatives of the executive team. So where that's really, to me, where that executive leader comes in, is that they have to really be great communicators. They've got to put the program first. They've got to not only help the executive team understand the needs and the requirements of the program, but also be able to execute the initiatives of the hospital, and sort of rally all the troops together, and then finally sort of pull in the folks on the ground day to day. So I think it's a much bigger role, where surgeon champions are basically, to me, folks that just love robotics, people that are just all in on robotics to improve patient care, to improve outcomes, and they're great to have on your team. And they're folks that also who are willing to row in the same direction as you, and to help you as a program achieve your goals.
Dr. Stiflman, I think those comments really hook into my next question as well. When you think about being, this leader being sort of the interface or an expert communicator. So I'm wondering how you personally recruited and engaged your C-suite to participate in your robotics service line.
It was an amazing transition. It was back in 2009, the first time I did it. And I'll never forget, John Stahl was one of our managers in the area. And he said, you gotta meet your executive team. I'm like, well, what do you mean? I'm just a urologist. He's like, no, you got to meet with them. You got to explain to them what's going on and, get in front of them. And I was very reluctant to do it. And I just went ahead and I took a jump and I made a 30-minute appointment with the president of the hospital. And I sat down with him and I realized that they had no idea what we were doing, zero. And they had no idea sort of the amazing things that were happening. And it just had that aha moment that I need to get in front of the executive team at least quarterly, to make sure that, number one, they understand what we're doing, they understand our outcomes, they understand the data, and that we also understand what their goals are, and we understand what their initiatives are, so we can be aligned. And without that alignment, it's very difficult to be successful.
Great. Dr. Martino, Dr. Phillips, does Dr. Stiflman's experience mirror yours at all in your organizations?
Absolutely. It's very much so aligning with the interests of our executives, and really their interests are what's best for our community. We work at a large nonprofit in northeastern Pennsylvania, and our team looks to take care of our community, and as Mike said, align with that quadruple aim. For those of us that have been doing this for a while, it was the triple aim, and now it's the quadruple aim. And really, you start to think about what encompasses that, and the better health in terms of the care that we provide for our community, and really fostering and offering more minimally invasive surgery for our patients certainly has improved their outcomes. When we think about the better care that we provide, we've seen in both Melissa's and Mike's programs, as well as ours, lower length of stays, decreased transfusions, lower infections across the board. But what's most interesting is the cost, because what we found and we believe is that better care costs less. Let me repeat that: better care costs less. And we've been able to see that in our own population, where we can now bend that cost curve down. Because we can provide MIS surgery to our patients as well. And certainly in the experience, patient experience and colleagues, it's been exceptional. So it really aligns nicely with the quadruple aim.
Absolutely. And to kind of dovetail off that, I think definitely showing our executives the component of clinical benefit. Our executives were very comfortable supporting a robotic hernia screening event that we did, pulled a lot of people in from the community. I did some spots on the local news that just helped educate about the benefits of MIS. And when I would operate on those patients and after that event, I really enjoyed passing my COO in the hallway and saying, hey, I found 23 hernias Saturday in this 3-hour window. And hey, I just brought this guy back. I fixed the best inguinal hernia on him and he went home the same day and he's doing wonderful. And he loves that you sponsored this event. You educated the community. You gave him a wonderful repair because of your support of this program. And I do think that that clinical view is not always what executives get. Sometimes they just get, I need, I want, this isn't working. And sometimes to be that positive light that says, you've given me the tools to have better outcomes, thank you, is a great place to start with that engagement. The other thing that Marty mentioned that's important to me is the cost factor. We did a lot of cost analysis, not only on our cost margin on things, and again, we'll, I think, get into that a little bit more here in the future, but it's another one of those things that you can keep doing as an ongoing thing. So for example, when we did our installation of our latest 4th gen set of systems, we put an X in day surgery. It was the first time our outpatient HOPD had access to the robotic technology separate from the main OR. And now I can go back and look at those cases over the past year. My laparoscopic cholecystectomies, which I think often gets criticized from a cost perspective in the world of general surgery, costs $140 less to be done robotically in our day surgery area and saves me 32 minutes a case. That means basically that I can do twice as many operations. And they love that data because it just supports the cost effectiveness follows all of the other things that I see as benefits, the better visualization, the use of ICG for identifying the common duct, things like that, that I, as the surgeon, appreciate the clinical benefit. They go, hey, good outcomes and the money's better. Perfect. So.
I'm just going to jump in and just add, something that Melissa said, which is so important to be, when you're going on this journey of being an ESL. We don't want to walk in there and say, I need this and we need that and this needs to get fixed. It's really about the attitude and being positive. And you've got to remember, one of the biggest roles that you will have is to be a good communicator and communicate those benefits often to them and loudly, and also make sure that you're presenting the data. And I think I'm going to end with that. I'm sure we'll talk a little bit more about data. But at the end of the day, communication is huge. Being that liaison is really what your role is. But most importantly, I would say it's you have to understand your data of the institution and be able to talk to that with a lot of expertise. And that really, I think, is what ends up being most successful. And you hear from Marty and you hear from Melissa, it's all about the data. And at the end of the day, it really could not be more true.
And I think that brings us to my next question, which is, Dr. Phillips, you and Dr. Stiflman both talked about this sort of the clinical information, like letting them know the real clinical benefits of this service, and also the cost information. And Dr. Stiflman, you're talking about the data, which is, we're all about the data. So I'm wondering if we can dive a little bit deeper into that data element, and that information element, like, what information is most important to hospital executives? What do you need to show them? We've already covered a bit about it, but I'm wondering if we can get even more specific. And Dr. Martino, you can start us off if that works for you.
Sure. I think, having a dashboard is absolutely essential. Working with your IS colleagues as well as the quality team to build that dashboard. And that will evolve and continuously improve and get better. But getting that step is important. And when you look at the data, looking at, length of stay is certainly important, down to minutes, not 1 day, 2 days only, bring it down to minutes. Looking at readmissions, for sure, looking at complications, certainly capturing patients who are high, comorbidities, majors and minors as well. And the whole list of data variables that a lot of these systems will give you is remarkable. So starting with that, I think is important. But I would look at length of stay, readmissions, complications, and then cost as well. Mike, what do you think?
I agree 1,000%. And again, I bet you Melissa has a very similar dashboard, right? I'm looking at Melissa and I see her shaking her head. You can't do this by saying, give me the data from 6 months ago. It has to be done in real time. because a lot of decisions that you're going to make is you're going to need to figure out quickly, a couple of months, 2-3 months, if it's working or not. So the dashboard is critical. The things that we look at specifically are very similar to Marty. We added a few more. We look at length of stay. We look at CMI, adjusted length of stay. That's a big metric for us at Hackensack Meridian Health. We look at readmission rate, discharge to home versus SNFs versus nursing homes, mortality rate. We look at transfusion rate. We look at PSIs, which are safety events. We look at surgical. We're able to look at surgical site infections. And we've added a couple other things. We've also been able to look at HCAP scores, aggregate ACAP scores for robotics. And that's been very, very helpful in terms of patient satisfaction and kind of proving that. And the last thing we've done is we've also looked at both case mix index, where the insurance are coming from, Medicare, Medicaid, commercial, and we're able to compare them to LAP and open. And finally, where they come from, how far away from the catchment area. And interestingly, at least in urology, I know this number, 38% of our patients come with outside of 25 miles from our catchment area. And just kind of consider that for a second. Hackensack is 11 miles from New York City. Yet we've got close to 40% of our patients coming from all over the New York area to Hackensack for their care. And when you show that to the administration and you explain to them that, we're branching out of just our 10-mile catchment area, and this is helping us do that, that's a very powerful statement for them to see.
Absolutely. Totally agree with what you both said. Definitely all of those things on the dashboard are important. I guess the other perspective I would take on this question is one of the things that my executives were very valuable in assessing at the beginning was opportunity for growth. So we used Intuitive's help through the market analytics group to do an assessment of where our potential growth was, where our open operations could go minimally invasive. And that component as well was the additional thing that would not be kind of the, day-to-day, week-to-week, how are we doing kind of an assessment, but I think is important to do on quarterly basis, every 6 months, something to that effect, because we ended up going from 2 SIs and 1 XI up to a 5 fleet 4th gen system because our utilization and our opportunity for growth said that that was worth doing. So I think you've got to definitely look at those things on a more daily functional level, but don't forget that bigger picture, which is as that surgeon leader as compared to the surgeon champion, how can you continue to grow and expand that program? Don't let it just be, as you mentioned 10 years ago when it was GYN oncology and urology. How do you make it not the niche so that everybody can improve their results?
So it's really about, having those daily real-time metrics while also keeping your eye on the future, the big picture.
I'm just going to ask a question to the other two, because I'm just curious, how often do you look at that dashboard, Marty and Melissa?
Yeah, we look at it at least weekly, if not twice a week, looking at growth, looking at volume. We've with Epic, we've got the ability to have this, as you probably do too, this incredible data resource, so we can see the volumes, and we've been able to grow our program with that. Just like Melissa said, from 7 platforms up to 11. We, several years ago added additional 4th gens to our fleet, and our general surgeons now, we've been able to flip rooms and stagger rooms, which has really been remarkable. Now that we've got the intelligence to see that, where, when skin is closed on one case, skin's open on another, and stagger, the surgeons are excited. They're thankful. The patients can have their access to the care, and it's a win-win for the community and for everyone. So that's what the data has allowed us to identify when we can stagger our cases and budget our surgeons to do whether it's 6 or 8 cases a day across the board.
I have to jump in there. I'm never going to leave Tennessee because I love it here. But man, if you can get me that efficient with 2-a-day surgery, I would love it. So,
Melissa, how often do you look at your dashboard?
I have to confess, we're not on Epic, so my dashboard is a little bit more cumbersome to get than just being able to log in and pull it up.
Yeah.
I tend to have access meetings to talk about those with our VP of Perioperative Services. And honestly, because I'm logging all of my cases and my personal stuff, I look at that a decent amount. But we do our robotic steering committee, and I know we'll get into some of the details of that on an every other month basis. So that's when that is sort of publicly shared. But I think we happen to pass each other in the hallway and chit chat about it a lot more, especially if there happens to be a yellow flag or, oh, COVID impact. Hold on, let's talk about how we're making up these cases and things like that have been going on a lot more recently.
How about you, Mike? How about yourself?
I'm addicted. Honestly, I probably will look at this. There are points where I look at it every day. Like, so when we upped the game and got our 5 robots and, we had a goal, I had a hit. Like I kind of said, we're going to do these X amount of cases this year. It was addicting. I could not stop looking at it. I'm down to about twice a week now with therapy, but hopefully I'm going to get to once a week.
Good.
Well, Dr. Stiflman, I'm glad you're walking that road to recovery. But we'll talk. In addition to those challenges, this next question. We'll talk about some other challenges. So the next question I have is, what were the biggest challenges you faced immediately after assuming a position of leadership in your robotics program? And Dr. Martino, we can start with you again on this one.
It's a great question. The world back then, as we said, was very much different. And once we started to do this, we would see in 3D, which clearly I think is better than 2D. And we would invite our surgeons in to say, hey, you want to take a look what we're doing? And they'd say, wow, I can see better. We'd say, yeah, it's 3D. And then suddenly it was almost like a swarm. There were so many people that wanted access to the platform. So that was one of the biggest challenges, actually, was to try and determine who, where, when, and why. So I would have I would sit down and onboard our surgeons, talk with them. I was fortunate to have our chairman of surgery that I'd work with very closely, and our program at the time was within there. And the first question was, why? Why do you want to join our team? And let them talk and listen to them. And if their values and their core values aligned with ours, then we'd invite them on the team. And we, at the time, envisioned we built what we'd say is the dream team. And don't have Mike or Melissa on here, but we're all on this robotics team of one. And it's really been remarkable. That was the biggest challenge early on, to build it. And of course, now, as it grows, kind of keeping track and managing the teams.
Excellent. Dr. Stiflman, Dr. Phillips, anything to add there about your own experience with some challenges?
So, yeah, I've done it twice now. So I started this being like this executive leadership position back in 2009 when I was at NYU. And then I left NYU, came to Hackensack in 2016 and did all over again. And interestingly, I could tell the audience, they're very similar challenges in 2009 and 2016. And you'd be a little surprised. You'd think we would have learned something in those 7 years, but they're similar. And I would tell, if I had to give a sort of a rank order, trust is number one. Getting people to trust you, that you are looking out for their best interests, that you are looking out for the program, that you are looking to really help them and help the surgeon succeed. It was very difficult in the beginning. There's sort of a lot of skepticism, like, why are you looking at my data and why are you showing me this? And why is this important to you? This is, my block time, blah, blah, blah. So getting people to trust you that it's really going to help them in the future was huge. The second biggest piece is getting access to the data. That is something that just takes time and persistence. And again, the same idea of getting the folks who sort of own the data, have the trust to give it to you, and getting a lot of times calling upon leadership to help you do that. And then third is keeping people engaged. It's easy that first meeting or the first 2 meetings, but those, quarterly meetings and keeping people engaged and making constant looking out of the box to improve things. I've been doing this now for 11 years, is challenging, but super important. Because things are changing and we always have opportunity for improvement. So trust, access to data, and making sure that you keep moving the ball forward.
I think that's beautifully articulated. The access to data was the point I was going to make. Our guys have taken it so far that we not only just get our access now, but for example, we get a case report card every Friday night at 9 p.m. that comes. So all of my cases for the week, I can see my supply costs. I know how to compare them. I'm compared to all of the colleagues in my service line, and I'm also compared to all of my colleagues across service line that do that same procedure. So if the urologists are doing robotic adrenals better than the general surgeons, I now know that they're saving $200 or we're saving $200. And it opens up that communication to be able to get everybody moving forward. So I think definitely getting that access to the data has really, it was initially challenging. And I think that's one that we have been able to overcome nicely. The other viewpoint that I faced, and I think I'm a little bit greener than others in this, I actually started as chief of staff for the hospital in a leadership position the same year I trained on robotics. So it had the advantage that a lot of the perks of my enthusiasm and a lot of my initial data that I was collecting looked great. But my challenge at that point in time was I didn't have larger views of what you could do, even though I had sort of that position of ability to influence change early. And I think that challenge was a different perspective. I expect that most probably won't be in that, but I was slower on my robotic training because I didn't get it as a resident or a fellow. So it was an on-the-job learning. And that component of realizing it's great, but also wanting to validate everything 6 times before I kind of said, wait, I can have this influence over this wonderful thing, gave me a challenge with that scenario.
I think you all laid out some great stuff for our attendees today. And I'm really struck by how often communication comes up as such an important piece of this in all of your roles. The next question I'm going to throw to you, Dr. Stiflman, to start. Should robotics programs be operated as a service line?
100%. I mean, that is a no-brainer. It absolutely works best, I believe. Again, this is my opinion, when it operates as a service line. We did that at NYU very early on, 2009. We transitioned Hackensack in 2017 to run it as a service line. In fact, we've taken it one step further. And I really followed Marty's footsteps in this. I started off just at the Hackensack role, running the program there, and then realized we can roll this out to all the other hospitals in our health system. And Marty was very influential, and I learned a lot just watching him and seeing how he did it. And now it's a service line that we have rolled out through all the different, all the different systems. And what does a service line allow you to do? Number one, it allows you to control your own block time. That is huge. You cannot run this by working on the service lines of 7 different service lines that use the robot. It's got to be its own. Number two, it allows you to look at cost much more efficiently because you can build these dashboards and you can look at cost and utilization. Number three, it allows you to really look at your contribution margin a lot more easily to understand, how are we doing and what can we do better. And then 4, it gives the person that's running the program a little bit of, cachet, get things done. They're not just sort of, oh, you're just a urologist, don't, tell me how to handle it. It's like, no, actually, I'm in charge of the service line and we're about a $21 million, contribution margin a year. So I think you should listen to what we have to say because it's probably pretty important.
Yeah, right.
So I think it really has helped us tremendously. I think it helps the program tremendously. And I'll let the others speak. And by the way, I'm throwing that number out. I don't know if that's true, and I'm going to walk it back if anyone wants to quote me on that. But
no, but Mike, you're absolutely right. We've seen this as one of the higher DDCMs, and VCMs that we may look at in terms of margins, and that's important. But I do want to go back early on. One of the themes I think that I've learned from Mike is transparency, because we go back a long way, and I remember.
Yeah.
Mike saying, come watch me operate. I'm doing this procedure. And I said, yeah, I'd love to. And he let me in the operating room. And here's, June oncologist going to urologist in the room and, showed me how he was doing his cases, and it was very open and transparent. So as a surgeon leader, that really is important to teach. And I was always just so amazed with the courses that we would run together, to the world, between NYU and LVHN and Hackensack and elsewhere around the world, to be able to teach the techniques that have been done. And it really has transformed healthcare when we think about what was happening. So really, a really sincere thank you to Mike for leading on that. It's been remarkable. I look forward to continuing to do that.
Thank you.
Absolutely. I was going to say, just to jump in a little bit more there, I definitely agree. I think any robotic access should be treated as a service line. And the additional point that I would make in addition to yours, Mike, would be that it encourages that team-based approach. And I know we're going to get into talking about our team here in a few more minutes, but getting that buy-in from the team, whether it is opportunity for improvement in the operating room from your scrub tech and them feeling empowered to share that with you, whether it is all the way up to your leadership structure about who do you put on your steering committee for robotics, how do you go about negotiating change and growth through different service lines. That team approach does not exist. It is a competitive approach if it's not a service line and everybody's together on the same side trying to make it better for the hospital. So I think that's the last and final piece that I'd add on that.
Dr. Martino.
Yeah, just one more piece on the service line. Absolutely agree. It's important. When we started this, we went to our finance team and we said, we'd like a service line report. And they said, that's great. We'd like to give us that. And that was really instrumental to giving us the data. And that was early on. So, I would absolutely encourage the surgeon leader and the executive to get that finance report so you can start to look at these variables, because now you can speak with your C-suite about all these numbers that come through. That's number one. And number two, it's real important to make sure that there's a position like a medical director or a chief of this service line, someone to oversee it, to do everything that Mike has been doing. So takeaways for sure.
I think we're talking a lot about collaboration right now, so I want to go ahead and dive into that team portion of our conversation, our discussion here. So the question is then, who are the members of your primary robotics team and how have you empowered them to take ownership of the robotics program? And Dr. Phillips, you can start us off with this one.
Absolutely. So to me, I kind of approach that question in two ways. The first is that my primary robotics team on a day-to-day basis consists of those that are in the operating room right there side by side, sweating through all those harder cases and enjoying the easy cases, right? That's my scrub techs, that's my nurses. That is my pre-op team, helping me remember that all of my robotic cholecystectomies need their ICG an hour before surgery. And I think the key to that group is empowering them that they are your team, respecting them every single day, giving them the autonomy to say, hey, I think we can do this better. I take, for example, my scrub techs. I am a less disposable oriented person than some of my colleagues. And I started later than they did. So we just started with their cards in the OR table. And after the first 5 cases, those scrub techs would look at me and they would say, you haven't used this for 5 cases and it's costing the patient $70 each case. Do you really want us to open this? And I love that they had that autonomy and that empowerment to help me get more cost effective. What I also discovered is that I personally, I think, have the fastest turnovers in the robot room because they don't open a bunch of stuff. If I don't use it on every case, they don't open it at the beginning. And that parallel processing that they've developed for faster turnovers, I'm getting 11 and 13-minute turnovers in our day surgery area between robotic cases. And my partners are so stinking jealous because they're not getting that on their regular general surgery stuff. And it's awesome. But that team has really been the group that has been able to optimize that. On the next level up, and again, to me, that's sort of the difference between the surgeon leader and the surgeon champion level of a discussion. That next level up is, to me, the team related to your administration of the program. So more your robotics steering committee component. So setting up that robotics team so that you've got people at all the different levels that you need. as was mentioned earlier, definitely you need a surgeon leader in that group. You also have to have other key players from your hospital. You've got to have your VP of perioperative services. You've got to have someone from sterile processing and central supply to help you know how that's going to work. You've got to have your hospital executives so that when you would like to accomplish something larger than what you can do, you've got someone in your corner that's supportive of that, has seen the data, and is ready to take it to the next level. So I think my robotics team, I kind of divide into those two categories depending on what level we're looking at. But I think getting everybody working together and enthusiastic and feeling that sense of, I want to make our program the best it can be, is really the important part.
Dr. Martino, Dr. Stiflman, anything to build on there? I think that camaraderie piece is, again, circling back to that, you got to be an expert communicator and you got to be engaged with folks and you got to have that important two-way. Is there anything to add there, Dr. Martino and Dr. Stiflman?
I'll certainly add, it's a fun job, right? We enjoy ourselves. I've seen a number of physicians doing this and, Mike, you're one of the best. But he loves it. He's checking his dashboard twice a day, right?
Twice a week now.
Twice a week. But it is enjoyable. And our team is there, and they're our team. And I think that's what's important. So team building, we've done some community events and we go out their team and, we would do robotic simulation Olympics in the past. We'll do different community events with our team. We'll bring the robot out as well. Now we let our kids, not our kids, but our community's kids have what's called the Healthcare Explorers Day. We invite our whole entire team down. And then we used to have it in person, now it's virtually, and we let our elementary students communicate with our team members. So all that's enjoyable. We have First Assist program, I would add as well, that has really helped us operationally. In addition, at that table that Mike will talk about, hopefully, is also our learners. Our residents, fellows, as well, are an integral part of that. Thinking about their team members and marketing, all helps to build the right message for our community. So, and it's a reiterative process. And you take your steps, you build it, you look back as well. But we also have a vice president of periops, as we've heard, and also an associate. I thought was important because when the medical director is not there, they're having someone else who can be there to help me as well. So in our world, we have someone in surgery and in OBGYN, and we found that to be helpful in our institution too.
So just to, I guess, talk about the way we do it at Hackensack. The way I look at this is sort of a vertical integration, and I think everyone touched on this. You've got your day-to-day folks who are on the ground. You've got your executive suite, which is up here, and then you've got what I would call the robotic team, the robotic committee. And that's that committee that sort of gets the information from above and figures out how to disseminate it and to make it happen. But also, more importantly, and I think Melissa touched on this, that's the committee that when there are problems on the ground, when there's issues with turnover, or we're having difficulty with 24/7 access, or we're not able to get cases on, even though there's a robot there, that's the committee that they go to fix the problem. So that sort of robotics committee, which sits in the middle of that vertical integration, I think is the most important. And specifically, we meet quarterly now. We used to meet monthly, but now we're quarterly. Who sits on that committee is every division has a leader. So general surgery, GYN, thoracic, ourselves sits on the committee. We have our head of booking, basically, our head scheduler in the OR sits on that committee. Our marketing, we have a person that's assigned to us for marketing sits on that committee. Someone from finance sits on that committee. Our director of perioperative services comes and sits on that committee. We've got about 11 or 12 people in the room. So basically enough to fit, 2 pizza pies to cover everybody. And it's a good meeting and it's a good committee because people keep coming back and things are happening, like things get done. So at that committee, we'll look at, we have a bunch of different things we do each time. We will look at block time And we will start redistributing block time if necessary, or at least giving warnings. We will look at cost distribution and what we're doing to standardize things. And so it's not just a meeting to have a meeting, and when you do this as an executive leader, I think a really key important point is when you start having these meetings, you start having these committees, you have to walk away with an actionable item or three, and they need to get done before the next time you meet, because no one's ever going back, right? You got one shot to make this work and get people to trust you. And so when you start doing this, go for low-lying fruit, go for something easier, but make it happen. And when there's a buzz that's going to happen around your committee, like that's a meeting people want to go to because they know things are going to get done and will be addressed. And that's who's on our committee. And then finally, from the executive team, it's like 4 people. It's my president, it's my head of perioperative committee, it's my head of nursing, it's me, and maybe someone from strategy. So we're just sort of sitting around, just going through the numbers and validating what we're doing and giving us some direction if we need to make change course.
Thanks to all 3 of you for really, discussing and laying out how that works at your respective organizations. And I know we're pushing up on time here, so this will probably be our last question. I think we've got a minute or two. So the question I want to ask then is to end on the sort of leave our attendees with sort of an action item. What is the first thing you would recommend to a new executive surgeon leader to do to start moving his or her program in the right direction? Dr. Martino, we can go with you to start.
I would say think about your core values and then work off those: collaboration, teamwork, striving for excellence, I think is the most important thing. And know that, if at first you don't succeed, try again, because we're all examples of that. For sure. So focus on your core values and then move on from there.
Dr. Phillips, how about you?
I was going to say, I would take it to the quadruple aim focus. In terms of starting as that new executive surgeon leader, you've got to figure out a new language for communication. You've got to take your clinical component to that institutional level. You've got to learn to talk about return on investment. You've got to learn to talk about cost and value ratios. So acquainting yourself with that terminology so that you can translate what I get great results, to what they need to hear, which is, here is why this is beneficial to our system, to me is the most important thing. And then keep your enthusiasm being the thing that I would give you as your takeaway point. You went into this and you love this because you think robotics are amazing. Do not let the ROI, the Excel spreadsheet, the anything else crush that enthusiasm out of you. If you don't love being the leader, go back to being the surgeon champion. There's nothing wrong with either group. Everything is not for everybody, but decide how you want to love robotics and take that piece and grow that piece the best you can. And if you do it as a surgeon leader, that's wonderful. If you do it as a surgeon champion, that's also wonderful.
Great thoughts there, Dr. Phillips. Dr. Stiflman, final word.
Some great input and insight there. I would say, there's 2 pieces to me on this question: actionable items and sort of resetting what you're doing. Most people who fall into this executive surgeon leadership role, this ESL, probably don't have that much experience. I know I didn't have a lot of experience in it. So for me, the most important thing was what Melissa was saying, like just understand the language. And the actual item there is really sitting down with either your chief of strategy or your CEO or your president, whatever that title is, and just sitting down for a half hour and just understanding what's important to them. So before you go and let them know what's important to you, meet with them and find out what's important to them so you can better strategize. The second thing, though, which is kind of points to Marty and the core value piece, is, you need to be very altruistic here. This is not about you. This is not about you getting a new robot. This is not about you getting more robot time. This is not about you getting, your name on a billboard. This has nothing to do with you. This has to do with the program. And, it's a cliche thing to say, but I say it all the time. Rising tide raises all the ships. And that if you can raise your program, you will raise your value and you will raise your referral and everything will work out. But really, it's about putting everyone else first. And when you do that, that will also help you with the trust, and that will help you with the growth.
It really speaks to the quadruple aim, right? Like it's really about the people, right? It's about the team members involved in the program, and it's about the patients. So I think that's a great place to leave things. It's been a wonderful conversation. Dr. Martino, Dr. Phillips, Dr. Stiflman, thank you so much. And thanks to Intuitive for letting me be a part of this. And thanks to all of you for tuning in. Thank you so much.
Thank you.
You're welcome. Bye-bye, everyone.